Thank you. So I think we'll begin. I want to welcome everyone to what I hope will be a very interesting and educational symposium. This will be a case-based session focused on a case of zero contrast TAVI with the use of a novel full-body embolic protection filter. The objectives are to understand clinical scenarios where a zero contrast TAVI protocol can be considered, to learn how to perform a zero contrast TAVI procedure, and to describe a novel full-body embolic protection filter for use during transcatheter structural heart interventions. I'll begin with introducing our panel. I'm joined by my good friend and colleague, Dr. Alexander Abizaid, and an excellent panel of expert discussants, Leonard Conradi, Fabio De Brito, Won-Kun Kim, and Helga Mollman. I'll begin with an introduction around stroke and the state of embolic protection. We'll then turn it over to Dr. Abizaid for an introduction to zero contrast TAVI and recommendations for embolic protection in that setting. Then Dr. Mollman will introduce the design features of a novel full-body embolic protection filter. And then we'll move to the case. Fabio De Brito will moderate a zero contrast TAVI procedure with use of the embolic protection device. And then finally, we'll have some discussion and opportunity for key learnings. I wanted to begin then with just a brief discussion of stroke in TAVR. Stroke was identified, as you know, as an important complication very early on in our TAVR experience, with an average of about 4% incidence in the early pivotal trials. And we learned even then early on that stroke was also associated with substantial adverse morbidity and even mortality after the TAVR procedure. Stroke was understood to occur due to the liberation of embolic debris at all stages of the TAVR procedure, as our wires and catheters cross the aortic arch, which is often diseased, with manipulations including balloon as well as valve implantation of the aortic valve complex itself, and even after the procedure with valve thrombosis and atrial fibrillation. And several series have affirmed this, including this early multi-center cohort, and more recently a large-scale analysis from the TVT registry, clearly showing that the vast majority of TAVR is an acute peri-procedural complication of TAVR. It often occurs in the very first day, or 75% within the first 3 days. And 95% or more of all strokes will be ischemic and major, often associated with substantial impairment in functional recovery, quality of life, and so on. And although the numbers have clearly improved over time with iterative improvements in our devices and procedural techniques, this remains a problem even in the modern era. And we see stroke rates after contemporary TAVR of around 2 to 3%. And concerningly, as demonstrated in this analysis from the TVT registry, stroke may not be subject to a learning curve and improvement as some other complications of TAVR are. Even experienced centers and experienced operators deal with this issue. It's also very likely that stroke, as I've shown, for example, from the TVT registry, is substantially underreported after TAVR. And we know from the studies that have used routine neurologic imaging, such as MRI, and proactive examination by neurologists, the stroke rates are clearly much higher, anywhere from 10 to 20% or more. And even beyond clinical stroke, when we do detailed DW MRI analyses, we find new ischemic brain lesions in the vast majority of TAVR recipients, anywhere from 70 to 100%. Most of these subjects will have multiple infarcts, and we know that these so-called silent infarcts, at least in the neurologic literature, are associated with adverse future events, including stroke, mortality, dementia, and so on. All of this raises the obvious question of what can we do to protect the brains of our patients? And this is what has made the development of cerebral protection devices such an attractive target of innovation. At present, there remains a single broadly available device, that's the Sentinel device, which is a partial intravascular filter. But there are new devices, multiple of them, entering various stages of investigation. These really fall into two broad categories, those of arch deflectors. These provide more complete cerebral protection, but do not capture debris. Rather, they deflect it to the lower circulation. And then capture and removal devices that provide complete protection, not only of the brain circulation, but the entire distal aortic circulation as well, and offer the opportunity to actually capture debris and remove it from the body. The Sentinel device, as I mentioned, is the only broadly available device. It's a partial intravascular filter that protects 2 of the 3 vessels to the head and the neck. It's been clearly shown to capture debris in more than 99% of TAVR cases, and has been shown to be easy to use and safe. However, its clinical efficacy in presenting stroke has remained uncertain, even in large powered stroke trials, most recently protected TAVR. And concerningly, we've just recently seen this release from the larger BHF Protect TAVI trial, in which the monitoring committee halted the trial because there's little prospect of demonstrating a benefit and even a potential for harm. Again, calling into question the efficacy of the Sentinel device. I think this has provided an opportunity and really opened the field to multiple new entrants, and we'll be focusing on one of those exciting devices in the remainder of this session. This is the embolic device, a full body protection device with debris capture and removal. And Dr. Mollman will give us much more detail about this device and the clinical investigation pathway. Before that, though, I'm going to stop and turn it over to Dr. Abazaid, who's going to speak to us about zero contrast TAVR.
Thank you so much, Tamim. In this next few minutes, I'm going to touch bases in 2 clinical issues when we are talking about elderly patients that will undergo TAVR procedures, renal failure, and potentially the prevention of stroke. I will start with my potential conflict of interest. And just a single slide to highlight and to remind you the impact of renal failure after TAVR. It's been in several studies an independent predictor of adverse events, and it's not trivial since the prevalence of lower clearance in these elderly patients is extremely high. So this is the proposal, and I give credit to Fabio Brito, which is sitting next to me, who developed this protocol in our institution at INCOR in São Paulo, Brazil, that uses several tests and investigation process without the use of any contrast, starting with the CT scan with no contrast, so you will understand some of the features and some of the characteristics of, for instance, calcium distribution, which is important. Also, the amount of calcium in the peripheral arteries where you're going to have access. We also performed MRI, which will give you more information and some diameters and help us with size in terms of perimeter and diameters. Also, we use TE prior to intervention, so we measure the valvular enodiameters, the valvular sinus diameter, the sinus of Valsalva junction, and coronary height. So we try to collect as much data as possible without using any contrast at all. And finally, we are using CO2 angiography to have to evaluate the access, not only calcium distribution with non-contrast CT, but also to be able to measure diameters of the iliac and femorals. The sizing will be essentially according to the mean Valsalva sinus diameter measured by the non-contrast CT and confirmed by TE, and the valve selection was the self-expandable Evolut valve. I think it for when we are semi-blinded in terms of measurements, not using contrast, we need to have a valve that is more forgiving in terms of sizing, and by doing that we have a trend towards oversizing a little bit because we measure this Valsalva sinus, and without compromising safety, since a self-expandable valve can accommodate the size of the annulus without major complications such as annulus rupture. During the procedure is absolutely guided by TE. So we can see in this example that you see we aim the height of the valve. You use, of course, the pigtail and the calcium parameters. But most importantly, TE will guide us throughout the procedure. We did collect data on 75 patients, the first 25 patients in a pilot study. You see that by using this technique, we had very acceptable results and low rates of complication. Just a single patient increased a little bit the level of renal failure, and one major vascular complication that we dealt with balloon expansion due to a residual stenosis. And then a quick slide for rationale that zero contrast with TAVI really reduces the renal injury in high-risk patients, but also full-body embolic protection may also reduce risk of acute renal failure by preventing embolic injury in these patients that already have impaired renal function. First generation filters are limited, do not protect all three branches, do not protect kidneys or lower body, and questionable efficacy data as Tamim just shared with you. And second generation filters should provide full body protection and broad applicability beyond TAVR. So this is, again, my final slide, just highlighting the potential benefits of having a filter that not only will protect the three vessels that goes to the brain, but also full body to perhaps to prevent more injury to the kidneys, but also peripheral embolic phenomena. Thank you so much.
Thank you so much. Thanks. That was a really nice, perhaps my microphone's not on.
Yeah.
Thank you, Alex. That was a really nice introduction to treatment of this very difficult patient population with kidney disease, and aiming to use strategies such as low contrast or no contrast evaluations to more safely treat them. Maybe I'll stop just for a quick question to Drs. Conradi or Kim. You know, this is a relatively frequent clinical dilemma. We'll see how our Brazilian colleagues handled it in this case. In your centers, when you're presented with a patient with fairly advanced kidney dysfunction, what are the steps you take of what's been mentioned in the workup, number one, and number two, perhaps in the procedure itself?
So I have to say we are kind of traditional with that regard. I think CT is still our major planning tool up to now, which of course implicates use of contrast. Now for the procedure itself, this is something that we do take into consideration. I remember Uli Schäfer, who is in the front row here, telling me that renal failure is the number one killer in cardiovascular procedures, and that is true. So we try to spare contrast as much as possible, but still, I have to say, stick to more traditional treatment algorithms.
Yeah, I would agree, actually. Usually you can do, with modern scanners, you can do CT scans with very little amounts of contrast agents. I've done a series actually also with no contrast, and it's possible to measure most anatomical structures, sinus of Valsalva, but for the annulus measurement, you can only achieve a rough estimation. So I think it's very compelling that you add measurements from other imaging modalities as MRI and TEE.
Yeah, and that's generally been our approach as well. The non-contrast CT, you can usually get most of the information, pairing it with TEE for annulus measurements, and even iliac IVUS sometimes if there's questions about certain areas of the peripheral access. That's great. Maybe we'll have Dr. Molman then join us and introduce the Emboliner embolic protection device.
Yeah, thank you very much. And I'm happy to share some design features of this new protection device and the ongoing trial. So we are talking about the Emboliner embolic protection catheter, and this has somehow a new filter design. It consists of a dual-layered soft nitinol mesh, as you can see here, which starts in the ascending aorta, protects all supra-aortic vessels, as you can see here, and goes up to the descending aorta here. It's designed for a very easy use. It's compatible with all existing TAVR systems, and it confirms to more or less all aortic anatomies. Of course, this one-size-fits-all concept is not entirely true. If you have a large aorta, it does not work. But in really most patients, it's absolutely feasible to have a full protection of the aorta. Here you can see the catheter. It comes as a sheathless device with an inflatable balloon tip, which enables a direct entry into the arteriotomy, so you can carefully push it forward and bring it in. This integrated sheath helps to minimize the insertion profile, so it's a 9.5 French equivalent. And the catheter is a quad-lumen catheter, which shows the TAVI guide wire on the one side and the pigtail on the other side. All this can be achieved with this ergonomic handle, as you can see here. Again, the system is 9.5 French equivalent. The sheath working length is close to 80 centimeters, and the delivery catheter is close to 1 meter, so the typical length which we know from other catheters. You can use a 035 stiff guide wire. This is important to notice. It's not meant for 038, so it's a 035 stiff guide wire system. And here again are the sizes of the aorta which can be treated, and I highlighted this before. Here's a short animation on how it works. So you bring the system to the ascending aorta, as you can see here, and then you unsheath the system, and this mesh will find its way above the complete arch. You have this port here, which is important to really catch all the debris later on. And importantly, you have this possibility to bring in a 6 French catheter and through the port the later device, as you can see here, and then develop the device, whichever device, that's your choice. Bring back the catheter, and then you can retrieve the filter device, as you can see here, and catch all the debris which developed during the procedure. That's pretty easy, and there are some clinical data around. So there were some early studies performed in Germany, Israel, and New Zealand. And in the moment, there is a IDE trial going on, the PROTECT head-to-head trial, as you can see here. It's a rather large trial, given the fact that it is randomized. So there are 250 patients in the Emboliner arm, and there are 250 more patients in the Sentinel arm, as you can see here. And the endpoints are given on the lower panel. These are the typical endpoints with a composite of death, stroke, and acute kidney failure, as you can see here. The PROTECT head-to-head trial is well underway, as you can see here. So a study started in mid of 23, and the actual enrollment is pretty close to the target enrollment, which is great for the time being. The centers are given here in Brazil, Germany, and the United States, and we are close to an interim analysis which should take place by the end of the year. Perhaps important, the valve mix as of October 24 was 2/3 Edwards and 1/3 Medtronic. These are the two valves which can be used during the trial. However, the system itself, of course, allows every given valve to be used, not in the trial, but in real life. So the trial enrollment completion is targeted for Q2 next year. In conclusion, the Emboliner is a next-generation embolic protection device which offers full body protection in patients undergoing transcatheter procedures. It is intuitive, easy to use, and has a one-size-fits-all approach. The head-to-head study is assessing the safety and efficacy of the Emboliner in a contemporary severe aortic stenosis population, and compares the Emboliner against the Sentinel, and we hope to see the results second half of next year. Thank you very much.
Thank you very much, Dr. Moman. That was a great introduction to the technology. I'll invite then Dr. De Brito, who will introduce us to the case.
So, Tamin, thank you very much. So I have the pleasure to present you a case that we recorded 2 weeks ago in São Paulo that demonstrates very well the technique of the non-contrast protocol, and also, of course, demonstrates the embolic protection device.
One more.
So let's make it very interactive. So
Absolutely.
Stop me when you have any questions, please.
Welcome to Lab 5 at TINCOR, São Paulo, Brazil. My name is Alex Abizaid. It's a pleasure to share this case with very experienced interventionalist here in São Paulo, Fábio Sandoli de Brito, who leads the structural program here at TINCOR. Very experienced also interventionalist, Henrique Ribeiro, and we are always very excited having to be able to train young interventionalists such as Bruno and Marco, who was also scrubbing in this case. The echo images today is led by Marcelo Vieira, a great team of nurses and techs, anesthesiologists, and some partners from the industry. So without further ado, let me ask Henrique to describe the case.
So thank you, Alex. So I'm going to present the case of an 88-year-old female with a very severe aortic stenosis, an aortic valve area of 0.4 in mean gradient of 75 with no coronary disease, that presented in the clinic with a dyspnea, New York Heart Association class 3. Her comorbidities included hypertension and diabetes, yielding a very impaired renal function with creatinine of 1.7 and a clearance of 27, finally with an STS score of 6.8. In addition, for this non-contrast protocol, we use the non-contrast CT evaluation with the sinus of Valsalva diameter to decide which device and size to use. And as you can see here, it's 27, 28 millimeters, the sinus of Valsalva diameter with very severe calcium in the leaflets. The coronary heights are very good, with the left of 13 millimeters and the right of 16. And also for the peripheral vasculature, we assess using the CO2 injection. And as you can see here, is above 6 millimeters in both sides. And also we use the calcium in the non-contrast CT. So our procedural planning is to go with a general anesthesia and TE guidance. So the TE is very important to assess the prosthesis height during the procedure using the Evolut Pro 26, and also very important using the Emboliner cerebral protection device, which is a full body protection that will be shown in a minute for you guys. So Alex?
This is an elderly patient, 88-year-old female patient with very severe aortic stenosis, symptomatic, mean gradient of 75, and a lot of calcium. One of the teaching points here that we're going to stress and discuss during this case is the fact that this patient has severe renal failure with close to 2 creatinine and very low clearance. And Fabio, any institutional protocol to treat these patients with severe renal failure?
Yes, Alex, we are using here a protocol that is based mostly on non-contrast CT for the planning of the procedure. We use 0 contrast at all, and also we do all the procedure without any contrast, based on fluoroscopy, the position of the pigtail, and guided by transesophageal echo. So I think this we're going to show during the case.
Great. And also another important issue is access, femoral access.
Yes, and access, we use the non-contrast CT to evaluate calcification, and also we use CO2 angiography to see the shape of the vessel, size, site of puncture, and everything.
Great. And another point for discussion, Henrique, is certainly a cerebral protection. I think this is under a lot of debate, Is there a particular rationale for this patient? The calcium score is over 3,000. Any particular, perhaps, subset that you would support the use of cerebral protection, you would recommend for most of our patients, or you still wait for more data?
That's a very good question, Alex. In fact, if you look deeply in the data, there's some data showing that in patients with a prior bioprosthetic valve failure, involving valve and in bicuspid, certainly more debris were captured. However, recent analysis did not show that in such patients the reduction in stroke rates were lower. So honestly, we are not quite sure if we should just use to all patients, or if we should select patients in certain circumstances. For sure, this patient, she has more than 3,000 of Agustin units in the calcium score, very severe aortic stenosis. So it's a situation where honestly, if this device would be available, I would definitely use.
So it's certainly an open field for improvement, right? And it's a great opportunity for us to discuss with you a novel device that not only protects the brain, but also full body. I think more debris to the kidney in this patient can be catastrophic as well.
Yeah. I think you also should mention that the patient is in the study, right?
Yes, exactly. So this is an investigation on the device in a very robust trial with more than 500 patients. The randomization is 1-to-1 against Sentinel, which is the current device which is approved here in Brazil and in many geographies around the world. So we want to see not only non-inferiority, but perhaps superiority, proving that we can capture more debris as opposed to the filter that goes to 2 vessels to the brain.
And maybe, Alex, then given the fact that it captures 5 times more debris than the current generation, maybe it will be meaningful in terms of a clinical stroke.
Potential advantage, and this, what Henrique just mentioned, was proved in previous study. That was the rationale for the study design, as I mentioned, 500 patients randomized against Sentinel. Well, I guess that for this zero contrast protocol, Fabio, it's important to highlight the importance of TE during the procedure. We're not going to use any contrast, so we're going to be essentially guided by transesophageal echo. Marcelo, can you give us some insights of what you see before the procedure?
Absolutely, Alex. We're going to use just 2 and 3D TE. We have here a transversal view as well as a longitudinal view. We can depict most beautifully that the aortic valve is absolutely calcified, not only the commissures, but also the 3 leaflets, as observed here. And also here by the 3D echo, we're going to see that the area is absolutely small, and it was measured as 0.4. And then the hypertrophy is absolutely huge. You're going to face a very challenging case, as demonstrated by here. Also, you can see the hypertrophy of the papillary muscles, as well as the whole ventricle. So the gradient we have as mean gradient 51 and peak rate 80 millimeters mercury. So it's a very challenging case, Alex.
Thank you so much, Marcelo. Now we're going to focus here on the setup, Fabio, and then we're going to describe a little bit in more details how we deploy the emboliner.
Pause 1 second.
So now we are going to introduce the embolic.
So,
Yeah, fantastic. Maybe we'll pause there for a second as you've introduced the case. I think we would all agree it's a high-risk patient, an elderly woman, very heavily calcified valve, advanced renal function. She has risk of stroke, as well as obviously acute kidney injury. I like the fact that you've emphasized the use of the TE and other methods to help guide the procedure. Another trick we've used is sometimes putting multiple pigtails from different access points and lining them up in each of the cusps. In fact, if you put 3, you can establish the annular plane, which is one of the challenges to help guide the implantation. We've also had some success with doing aortic root angiography with as little as 5 cc's of dye. If you do rapid pacing during the injection, even with very, very small amounts of dye, you can get a nice picture of the coplanar annulus. But any thoughts from the rest of the panel about the case introduced and getting set up to start moving?
Yeah, I think it's a very good approach for a highly comorbid patient. So, yeah, what you could also take into consideration, because for TE you need general anesthesia. I've heard from Japan, I have no experience myself, but you could also use ice for positioning. And what we do in our institution, we also use just wires for landmarking the aortic root. So this could be some alternative approaches, but I think the way you introduced it is very compelling.
And what about in your practice, Dr. Mohlman? Any thoughts about how you would approach such a case?
I find it really interesting, to be honest. I never did such a case before, so to be honest, we do not have the technical opportunities to have the CO2 for the vessels, for instance. I'm not sure. Don't want to criticize the approach, but I'm not sure whether the downside of the general anesthesia is not perhaps somehow equal to what you see with like 5 or 10 milliliters of dye. That should be discussed a little bit, probably. Yeah.
Yeah, just because contrast is not the only reason why the patient deteriorates renal function after TAVI. Hypotension and bleeding, and there are many factors that can contribute to that. But anyway, we know that using less contrast is beneficial for these patients. Another point that is maybe important in this situation is that these patients with renal failure, they present with very calcified valves, and then the combination of kind of reducing contrast and using cerebral protection makes a lot of sense in this situation.
Yes, there's somebody from the audience, Tamim, that is asking about potential brachial access for this device, Fabio, using sometimes even for radio 8 French, but or brachial. I don't think this is designed for brachial at all. Remember, the design of the filter goes up to the descending aorta, so I think brachial is totally excluded as a hypothesis for this solution.
Yeah, maybe one more comment regarding the sizing, because if you do not have contrast-enhanced CT scans, the sizing that you can achieve is only an approach. You will have some confidence interval. So I like your approach that you choose a device with some that is forgiving regarding sizing, because you will never be as exact as with CT.
Perfect.
Yeah, that's a really good point. You could always recapture and remove the device even and choose a different size if it ended up being inappropriate. So that is a nice part of the strategy.
So let's move on.
Liner system. And you see at the tip we have a balloon that makes it easier to insert the device into the artery. Then we go all the way to the ascending aorta, as you can see here, with a stiff wire in the level of the STJ, and we leave it there in between, a little bit above the STJ, okay? So now we can see the mark in between the STJ and the level of the innominate artery, so that's the level we are aiming for, okay? Yeah. Then we deflate the balloon and remove it. Leaving the wire in place. So just to remember, Alex, this is a 9.5 French device, and now we are going to deploy the filter, right?
Despite the fact that this is a 9 French device, Fabio, I think that the advantage, in one axis, you're going to deploy the emboliner, but also you're going to leave the pigtail as a reference.
Yes.
So that's going to avoid an additional access, such as radio, for instance, right? Yeah. Another radio.
So deploying is quite easy. You just pull back the sheet and deploy the filter. Mm-hmm. Until we see the port, and we form the port like this.
Yeah. That's where the debris is going to be captured, right?
Yeah. And then we finish deploying the whole filter.
Mm-hmm. Perfect.
Good position, right? So now the emboliner is deployed. and the pigtail inside it is well positioned in the non-coronary cusp.
You can clearly see that the pigtail is inside the port, right? And in the position that is going to help us to position the valve.
Yeah. Now we advance the pigtail, and the idea is to, of course, do it inside the emboliner and not at the side of the device. And here I think we're at the side, right?
Yes.
So
You're behind.
should do it again. Now we are clearly inside.
Yeah.
Let me
A little bit more support.
put a little bit more support here and cross it. And then we do a quick wiggle test just to make sure that we are inside the port and go all the way to the ascending aorta. Now we
pause here, maybe
exchange
just for
the
a second.
pigtail.
Let's pause. We've seen the deployment of the emboliner, and I think it brings up some really neat features. I think people may have appreciated the dilator on the sheath is actually a balloon, and that allows you, with this integrated sheath, to enter the body, advance it to where you want it. You then deflate the very tip balloon and withdraw that. The deployment then is a simple pin and pull, as Fabio beautifully demonstrated. It's really nice to me in a way that you don't have to spend much time trying to figure out the positioning. It's not finicky. You sort of just start near the SDJ and very simply deploy it. The port then forms, and you see that it's nicely visible, and how easy it is to tell, as you nicely showed with the pigtail, that you're actually central inside of the filter. Any comments from the others that have experience, using the device? What does it feel like in your hands, or how does it feel doing this deployment?
Well, the handful of times that I had the privilege to use this, I have to say this is what it really looks like. It is rather straightforward. It's very forgiving, soft material. So I would say this is what it really looks like. It's like you say, pin and pull, and then invaginate, and there you go, right? And then, like you nicely demonstrated, one big watch out is really to pass inside, of course, but in the cases I've done, it's easy to visualize that. So.
Absolutely. So it only takes a couple of emboliner to overcome the learning curve, and then it's performed pretty fast.
Yeah, one of the questions that always comes up with any arch-based device really is can it move, and is that an issue? And one nice thing about this device is it's a double layer. It almost feels, I wish we had one to pass around, it almost feels like a fabric more than a metal. And you get the sense, and you saw even with the pigtail, that there's a teeny bit of shifting. The port opens, it moves, but it feels very, very safe. Even if there's some movement, you don't lose capture. It's a very sort of safe, controlled feel, and you can easily maintain capture throughout, or coverage.
Maybe also one comment as emphasis for the audience that this is an additional axis, but you can integrate the pigtail that you would otherwise you need an additional access route. So you can use this. How do you do it? Do you use angioseal for closure, ProGlide? How do you?
One per close.
That's what we've been doing as well. One single per close. Yep.
Okay. So let's
by an AL1
Safe trip.
to cross the valve. So we crossed the valve. Now we are positioning the confident wire. Remember that it's a very hypertrophic ventricle, so we might need a pigtail here to adjust the wire correctly.
So Fabio, according to the zero contrast protocol, how do you select the valve type and valve sizing?
Okay, for the valve type, we always choose a self-expandable valve because it's a little bit more forgiving with regard to sizing. And also, of course, you can reposition if needed. That's a very important in this kind of technique. For the sizing, we rely on the non-contrast CT and mostly the size of the sinus of Valsalva. We can measure it very well with the non-contrast CT, the size of the sinus of Valsalva. And then we choose the largest valve that we can accommodate inside that annulus. For example, for this case, the sinus of Valsalva is 28, and then the largest valve that we can accommodate there, the largest evolute, is a 26. That's why we choose the 26 valve here. And this is completely different than we are used to do.
So when we measure the size of the sinus of Valsalva and it falls in between two sizes, then we go to the measurement by TE of the annulus or the non-contrast MRI, the whole heart MRI. But the vast majority of cases you can choose the size of the valve only based on non-contrast CT, and we don't need these extra modalities to define the size.
And how about BAV? It doesn't seem as though you're planning BAV in this case. I think you found it not necessary, or?
Yeah, it's for these cases, especially in this protocol with these renal failure patients, as I mentioned, the calcification is so high that we are pre-dilating the vast majority of cases.
Yeah. And it can help you with the sizing as well if you do that. Even, I mean, we have a lot of experience obviously with balloon sizing with contrast injection, but it turns out on TEE you can also see the extent to which the balloon fills the annulus, and that's another hint around your sizing.
We are used to use the size of the annulus, and now with this technique we're using only the size of the sinus of Valsalva.
I think there'll be no debate in a highly calcified valve like that we're going to pre-dilate. But for the zero contrast, do you recommend pre-dilatation in all patients?
Yeah, it makes a little bit easier to position the valve, and also these cases that we are doing with renal failure, almost all these patients had calcium score over 3,000. So they are very calcified valves that we almost always pre-dilate.
Great.
And in this case, we have chosen a 23 balloon.
No interaction with the balloon and the emboliner device, as you saw.
A little hard to cross even with the balloon, huh?
Yeah.
Difficult to cross.
Proves
Even
the point.
It would have been hard to cross without it.
Yeah.
Mean grade that was 75.
Can you maybe 23 millimeter balloon is relatively large.
Okay, stop.
23 what?
Balloon size.
Yes, it's a 23 for a 26 valve, so a good
Medtronic.
pre-dilation. Yeah, very effective. Yeah.
Sim. Removing the balloon, also, again, no interaction with the emboliner, passing the port very easily.
Yeah, you can see that the port opens, dilates, and closes as we navigate with the different devices, but with no interaction, it remains in the same location.
So now it's time to insert the 14 French 26 Evolute Pro Plus that we chose for the case. So let's advance the valve inside the port.
Beautiful. No interaction whatsoever to ascending aorta.
I think we're good.
And this is the valve that has the most potential to interact because the tip is more rigid. So for the other, for example, for a balloon expandable, a sapien valve, we saw even less interaction with the valve and the emboliner. So this is an example that it works really well.
So now, Alex, we're going to rely on the pigtail, the base of the pigtail that is in the non-coronary cusp, calcium markers, and also TE will show us the depth of implantation.
Yes, that's going to show us the value of echo to guide this procedure.
You're inserting the valve.
Still a little resistance, right? Yes.
So in the cusp overlap position, we start deploying the valve, aiming 3 to 5. We are very good.
Yeah. Now, Marcelo, if you want to see the echo.
We can go all the way, and we check by echo.
Okay. So Marcelo shares with us how deep we are.
Yeah, we can find the procedures that's almost like 0.4 centimeters from the ascending aorta into the VOT. It's a perfect place seems to be very nice. We don't have any problems with the mitral valve, and the pigtail is quite okay. So procedure so far, it is fantastic.
So I think we are a little bit too deep. Let's try to place it a little bit higher. Let's see if we can do it shallow. So now I think we are a little bit more shallow than the other one.
Let's see the echo.
Let's see what echo tells us.
From the echo point of view, it's 3.8. It is okay.
Okay, so let's deploy the valve here. Let's pull back the wire. Go ahead. Excellent. So I think it's a very good position. And the other very important point that TE help us on this kind of procedure is in the evaluation of PVL. Of course, we have to decide whether to post-dilate or not, and that depends on what we get on gradients and PVL. If we find a higher gradient or PVL, we'll post-dilate, relying only on echo.
From the 3D TE, we have a very new image. It should be almost like 3.4 from inside of the LVOT. This is
So we are very happy with
the position. Now let's see gradient and leak.
We can observe once again the periprosthetic leak just connected to the posterior wall, just close to the left atrium. Should be under the VARC range.
So I think that gives us a hint to dilate, right? With the same 23 balloon.
So let's see how we take the device out. Again, no interaction.
No interaction with the filter.
Aqui, ó.
23 balloon
Esse
up.
gradiente já ficou bom. O que não ficou bom foi isso, tá?
Pace off.
So Marcelo, tell us about post-dilatation. What did you find?
Yeah, we can just observe, Alex, before dilatation, the mean gradient was 4 and the peak was 10, but we can observe a discrete aortic regurg, a periprosthetic one. And after the dilatation, we cannot observe anymore. Just mild, just trace. And the mean gradient was 3.
Fantastic. So you did do invasive measurement as well, because it's part of our protocol here. Can you show us the hemodynamic, please? So Fabio, almost zero gradient by invasive evaluation, right?
Yes, I think the result is very good regarding that's a small lady, small annulus for sure, although we don't have the measure by CT, we know that it's a small annulus.
Great.
And the hemodynamics, as you can see, the diastolic pressure in the aortic curve is fantastic. So there's really no leak.
So now it's time to retrieve the emboliner.
It's getting inside the catheter. The port is going to straighten up, and everything is going to be inside the catheter. And if you see my hands here, you see how it looks. You see, all the debris should be inside this bag over here. This is going to be sent to the US, to Renew Vermani's lab, to be able to analyze independently the amount of debris we capture inside versus what we capture in the filter with the Sentinel. Now, Fabio and Henrique, it's time to pull out the catheters and do a CO2 control, right, to make sure that the access is okay with not too much stenosis or any bleeding.
Yes, Alex. So this is the final CO2 angiography showing a mild stenosis with very good flow on the femoral artery, and the pulse here is very nice without any bleeding. So we are very happy with the hemodynamic result of the valve and also with the femoral. And as you mentioned, all the procedure without any contrast.
And I have to say that this was a great demonstration. This is a very high-risk patient, right? With multiple manipulation, pre-dilatation, valve deployment, post-dilatation, and a good indication for the use of filter.
Valve recapture.
Exactly. So a lot of calcium manipulation. I think that we should be happy with the result. And at first,
totally with zero contrast at all, right? We didn't use any.
So two interesting protocols with cerebral protection and zero contrast. With that, I appreciate the help of everybody here at INCOR, the filming crew, echo, anesthesiologists, and the industry partners. Thank you so much.
Well, congratulations to Fabio and Alex both. That was really an elegant demonstration of the techniques of zero contrast, also the use of the emboliner, which was beautifully done. It was remarkable to me, even with 2 balloons, both pre and post dilation, as well as the relatively stiff core valve, very little movement or interaction at all. Do you want to talk a little more about your experience, even beyond this case, with the different devices and the emboliner?
With cerebral protection, you mean?
Yeah.
Yes, we only have experience, of course, with the Sentinel. We participated also in a study with another, but it's a deflector. We did only one case. And for what I can tell you with this experience that we have now, almost 40 cases, that this device is very simple, as demonstrated here. The deployment is simple, then retrieval is simple, interaction with other devices is quite good. So I think it's wait for the results of the study, but I'm very optimistic.
There is no perfection. I think there's always a trade-off. I think perhaps one downside was already highlighted, the fact that we're going to use another femoral 9 French. But I have to say, with the closure device, with a single perclose, we did not experience any bleeding complication or major vascular complication. And again, using the 2 femorals, avoiding other punctures and other access. You know, it's not perfection, but that if we prove that we can improve clinical events, not only cerebral protection, but we're going to have to pay attention to other embolic phenomena that we generally don't regard too much in our daily practice. So that might be, a novelty for the future.
Yeah, really nice use case for it. I think it's a very interesting way to do it, and I think it's cool also that you can appropriately position and maintain the filter even without contrast. You don't need to see the cerebral vessels at all because you're low enough in the ascending aorta, right? That even without contrast, and in fact, even in the patients where we're not following a low contrast protocol, we haven't found it necessary really to take pictures with this device like you would with some of the other devices where you need to manipulate the head and neck vessels in order to deploy it. Any other comments or questions from the panelists?
Yeah, also congratulations for really a good solution of a challenging case. One question regarding the procedure is how did you determine the implantation view? So was it a cusp overlap view? And you were very shallow actually. Would you, for such a case without contrast, maybe renounce to a very shallow position, maybe be a little bit more on the safer side? This is one question. And how did you verify coronary perfusion afterwards?
Excellent question. Yeah. So the implantation views, we can also do it by non-contrast CT because you can identify easily the bottom of the sinus to determine the planes. So it's very easy using also non-contrast CT. And which was the other question?
Coronary perfusion.
We also can measure the height of the coronaries, left and right. And as you have the size of the sinus and the height of the coronaries, you can estimate the chances of having coronary occlusion. For this protocol, we excluded cases of high risk of coronary occlusion.
Yeah, my congratulations, spectacular case. I have to say the use of emboliner without contrast, I think that is the way it should be. I mean, the standard, if you want to call it that, the Sentinel also works without contrast, and this is clearly superior for me in terms of ease of use and full protection, all these things we've discussed. For the TAVI part, I have to say, of course, you are extremely expert in implanters or in physicians. So, but can you tell us a little bit about the learning curve? Is this your standard protocol for all TAVIs patients? Is it just for those at risk for certain events? how do you select?
Yeah, it's essentially for renal failure, and this was again a study design in 2 steps. The first one, the first 25 patients. Well, the clearance was less than 60, and the next 50 patients, clearance was less than 30. So for the first pilot study, we end up having one final angiographic injection with little contrast, because one of the ideas, Leonard, is to compare all these methods and to have the correlation so we can mimic that without contrast. And that's what we did for the second half, the 50 patients subsequently.
Yeah, wonderful. Thanks.
Great. Well, I think we're coming down to the last few minutes. So maybe in summary, I'll just say again, congratulations to the team in Brazil. I think you've done an outstanding job of demonstrating some really important concepts. This includes the evaluation of patients and procedural planning in the absence of any contrast, focused on the non-contrast CT, the TEE, the CO2 angiography, and then a beautiful demonstration of how to do a case for these patients that are at high risk of renal failure in a very safe, controlled manner, but also sparing them the additional exposure of contrast. We've also learned about the emboliner device, which is a new device. We mentioned the clinical trial. This is the PROTECT head-to-head trial that's actively enrolling. We've reached the halfway point and hope to have the interim analysis here early in the new year. So I think much more news to come, but it was very nicely demonstrated, some of the potential features and advantages. So I thank everyone for their attention, and we'll wrap it up here. Thank you so much to the panelists as well.
Thank you.
Thank you.